I'm Laura, I'm the MDT coordinator for the team, and we're going to talk today about our QI journey, and I just wanted to say that our poster is over there, so please feel free to go and have a look at it. But I'll introduce you to the team. We've got Ravi, our consultant paediatrician, Liz, our lead dietitian, and Louise, our paediatric diabetes nurse. And just to give you a bit of an idea about where Torbay actually is, we're a tiny little park down at the end there, quite near to Cornwall. And we're made up of 3 towns. We've got Paignton, Brixham and Torquay. We actually cover a wider area as well. They go out to Dartmoor, across to King's Ash and various other places. And give you an idea of our caseload total there, we've got 133 patients with our breakdown here. And talking about our QI journey, when we started as a full team in 2015, just to give you a bit of an idea of what we were actually up against. Oh, no, it's okay, don't worry.
Are you sure?
Yeah, it's fine. Just to give you a bit of an idea of what we were up against, our results here from our Spotlight audit show that we were a lot higher than the average for our looked after children and children in care. And lead on to Ravi there.
All right, yeah. So in 2015, we kind of, as Laura said, that we started on this 5-year journey. Can we go back a slide? Is that, I think it's...
Sorry, I did that. It's my fault. Okay. Right. Where were we? Sorry, go on to that one. 4. That one? 4, yeah. Sorry, I'll do it. I've got the clicker. Okay, sorry.
We had this. We now at this point in time we had this team that was now, we had a full team. The funding had got through, and we'd got this full team, consummate to the task. We were outliers for care at this point in time, and we came up with this 5-year plan to get our HbA1c suited. I think it's worth on the previous slide to just note the figures here about the 709 per 10,000. So about 7% of our diabetes population has hit social services input, either looked after children or have had their involvement. And that's a significantly higher figure than the rest of the country, and something we didn't appreciate at the start of this journey. All right. So we started well. We started with a newly diagnosed guideline. We turned it into a pathway. Well, at least we could talk bullshit bingo at that point in time. We were buoyed by trying to integrate our process of trying to integrate the young person into the newly diagnosed into carb counting from outset, and that was successful. We felt that we really kind of hit our niche at that point in time, and we're started on this patient-centered journey. The initial direction was good. The average HbA1c fell, and patient feedback was good. But a cautionary note is our patient feedback has always been good, no matter what our HbA1c has been. Following on from this time, we looked for our next transformative project to make our fortune. It remains elusive. We had ideas, and we've never been short of ideas. Newly diagnosed education, social media engagement, videos, transition. We had all of these ideas. Download clinics. Some were tried, some were slightly successful, but many failed due to a lack of preparedness, resource, and focus. However, there was a warning, and you saw that in the previous slide, and I think the rest of it was in some ways reassuring this morning to see the data from the NPDA that actually the rest of the country did the same thing at the time. But there was a warning that from our data that despite our initial success, we were going to flatline. So we came up with more ideas, and they were kind of very clinician-led at that point in time, and I think we became quite paralysed by our analysis. And in 2017-18, we actually, from the data, despite a short period of being non-outliers, we became outliers again. So we stand before you as outliers.
Again.
It's probably worth looking at another significant factor to take into account for our caseload is the age group. We have this rump of older young people who are heading into transition, and I'll talk about that a little bit later. Okay, so where do we go next?
So we started, as Ravi said, we started to plateau a little bit, and then suddenly in came the QI. Was it wave 4 that we joined? And actually, it gave us a bit of focus. We actually joined up on the day, and I think Ravi would say that actually we were a little bit like, ooh, what does this mean? What's this language? We started changing I think it was from service development to QI project. We felt we were just kind of moving in the same direction, but it not necessarily giving anything for us to use. So actually, it was normally the fear of turning up to the next day and having to have something on paper. And I think it was something that Ravi found, actually, which was the fishbone, that actually was created by one of the Swedish teams that made us go, hang on a minute, we might actually be able to do this.
Because up until that point in time, we behaved like outsiders. We'd taken it to heart. For years, we felt we had to carry our head in shame. For starters, there's the letter that we've already talked about today. And our diabetes lead, Dr. Riley, Phil Riley, has for many years had to walk this walk of shame to the board to explain why we continue to languish in no man's land. And this year is not going to be any different. We ask the questions, what do we have to give? Could you ever really go to a network meeting and proclaim to be part of this team? We've got our fantastic colleagues in Cornwall who are out the other end. Could we ever look into our patients' eyes and really believe that we were giving good care? It takes strength to persevere through something like this, and it's not necessarily a spur for dynamism. However, going back to QI, I think that outsider perspective maybe allowed us to start thinking about how our patients might feel with high HbA1cs. How many times have you gone to clinic and told one of your patients who's poorly performing to go give them some practical ideas of how they can improve their control and come back, and they come back to clinic and they haven't? Well, welcome to our clinic appointment. So, back to the QI.
So back to QI. QI begins for us. We're hoping that our clinic appointment wouldn't be so bad, and actually these little improvements we start to look at might actually make us not be an outlier, hopefully, for next year. So when we looked at doing a fishbone, it was so big, I couldn't even put it on one of those size pieces of paper. We had so many ideas, so many thoughts.
So many areas that we needed to work on.
Absolutely. And it was, in the end, we came down to what we called the drifters. So moving on from our lovely newly diagnosed pathway where we felt we really had got it right for our patients, it seemed to really be improving. Care on the ward was brilliant. They were all on board with this, helping us to actually get this first good start for our patients. But what we noticed was actually 2 years post-diagnosis, these patients that had absolutely fabulous HbA1cs were drifting up. Could we make an impact?
And we know.
What could we do?
Sorry.
Go on, Ravi.
We know that. We knew we were outliers, and we had lots of advice. We were told that we could improve our HbA if we just concentrated on it, as if we hadn't got the message that HbA1c was such a valuable tool of measure. Even suggested that we might want to transition our 16-year-olds a little earlier. Is that fudging numbers? Our area, the need of our population, you've seen that statistical figure. We couldn't let these guys just transition. Some of them needed more support, a lot of them needed more support, and we're supposed to share this journey with them. So part of the QI was, whilst the drifters was that starter, what we realised is that, let's be frank, well, let us be clear. Just because we're outliers, we don't care any less about our patients. We don't work any less hard. We still have the same worries. We still care. We still want to provide good care. But we knew that we could change some processes and be really successful. The care processes. Little known fact, we're positive outliers the other way. And we did that a bit like Birgit, on a flip of a plan, and we worked through it. But something wasn't working for us in terms of our HbA1cs.
So when we looked at the drifters, it became quite clear that actually there was two, sort of, as you can see, two markers actually. We noticed there was something about the team, and we noticed maybe there was something about clinic. As I said about that big fishbone we had, it started to get bigger again, even with just the thought of the drifters. And when we looked at the team, we were looking at what was our statement. Actually, formulating QI meetings, we actually did a questionnaire for our team, because we were finding that actually, one team, one message, were we really all giving out the same message? The little bit of differences that we might say. And that is where our high HbA1cs, we felt that maybe we weren't doing them justice. Because actually that little bit of different communication from our team member might be confusing or just allowing the high HbA1c. So where we started off looking at the drifters, it has automatically already helped with the rest of our patient groups. So we did a questionnaire. It was anonymous. We sent that questionnaire to all of our staff. And actually, we were pretty much doing similar messages. There were just slight differences. And actually, we worked really, really hard to bring that in and to actually get us saying everything the same, so that our patients weren't confused, whether they saw Dr. Lehal, whether they saw myself, even if they spoke to Laura on the phone in relation to clinics, we were all singing from the same hymn sheet. Clinic, we looked at paperwork and the clinic experience, and we're still doing that now because we really still have not got that right. That is an ongoing project for us. But with the paperwork, we actually decided that if we wanted the one team, one message, what about our families that go home? They've got to wait sometimes for our clinic letters 4-6 weeks. That's halfway through, ready to come back again. And actually, what about families where the dad can only come to the clinic or the mum can only come to the clinic? How many of us sat in a clinic appointment or with a GP and gone, I've forgotten half of what they said? So actually, we started supporting them in writing down what had been said there and there, changes that had been made there and there, and a plan. And we did a very simple bottle top. I was smiling earlier when I saw the pasta, because actually we did it with bottle tops, green, red, orange. We got them for all the offices, got them to leave them for us, and we did a simple, was your clinic experience with the new paperwork good or bad? We had some great feedback. As Dr. Lehal always said, we've always had great feedback. We did have one we had to actually put sideline because the young lad thought he was actually voting to who won the Champions League this year. So we did have to kind of make it quite clear what we were actually looking at. But we realised that actually, even before we could look at all this, communication and the one team, one message was actually pretty clear. We needed to come together more. And we'd worked really well as a good team anyway, but we just didn't realise we could do better. So, it was a little bit about the fear of the going into the next QI day when we didn't want to disappoint Megan and turning up and actually not having anything more to talk about. And actually what we had done up in the last 3 months of the QI, it gave us structure. It made us think about actually what we were aiming to get out of it. So this was what we did in the months between the two QI days.
We became there's lots of it, we started to introduce small incremental changes. By this point in time, we'd found our navigational compass. It was a really good term that you used earlier on today. It was about the patient journey. We had to ask every time we wanted to make a change, how would it affect the patients? And we'd also broken into our team structure and said, we want to provide good care. We're going to have to talk about some of the elephants in the room. And we'd started to deal with that.
So, delighted to share with you some of the things that we actually have done from or during the QI project and following the QI project as well. And this morning, listening to the talks we've had this morning, we were so delighted to be sitting there going, we've done that. So really excited to share that we'd highly recommend the QI project. It's been a great journey. So these are some of the things that we've done then. So Lou talked about one team message, all wanting to be consistent, and also the value in increasing contact time as a team. And we've spent time outside, clinic time, and in new structured meetings. We have a better timed agenda. We have a team communication sheet where we share information about patients before we start clinics, the team questionnaire. And a huge thank you to all our fellow teams in the South West network as well. We've learnt so much from fellow teams. Thank you to Cornwall, you're here today. And also from our adult team as well. I think we're really proud in Torbay to say that we have a really good relationship with our adult team, and we've learnt an awful lot from them as well. And they have from us too. We set up new resource files to make sure we're sharing common information as well. Definitely technology, we know how advantageous this is in helping improve HbA1cs. We're looking forward to having new iPhones for the whole team in the future. That will make a massive difference. I'm a bit of a dinosaur with social media and so on, so I've given that to the younger members of the team to do. We're just about to start using the deep resources as well for education. We've started using iPads to collect Prem data. We've found that really successful in increasing the amount of feedback that we've had. We've looked at our clinic experience. So we've looked at our clinic outcome sheets and the way we handle information, passing it across to patients. We've got a top 10 tips sheet, which is really helpful just to summarise and help patients focus on what their goals might be towards the next clinic. We've looked at quarterly topics in the clinic area to enhance the education we can give during the clinic sessions. And really important as well, raising the expectations of what we would like patients to do, and not only from diagnosis but from clinics as well. And we think this is going to make a massive difference. And particularly focusing on helping people self-managing and really empowering them and giving them the tools and skills to improve things themselves. So this is our ongoing journey then. So our one team, one message theme. Definitely looking after ourselves as a team. We've really benefited from the QI project in coming together better as a team. We did already have a great relationship, but it really has enhanced that as well. We're looking at the clinic journey. That's ongoing as well. And I think our next focus is going to be on annual review clinics as well. Patient feedback, which you guys have talked about as well. Technology, we're looking at developing perhaps a download clinic, which might be nurses and dietitians, so using us in a different way. Education, we're looking at developing that further. And from a dietetic point of view, I'm glad to have two colleagues who are now back from maternity leave, so we've had a bit of a bumpy ride, but we're looking at how can we use dietetic time differently. And I must give Gemma a shout out from Cornwall because we pinched some of their ideas in how perhaps we can do school visits differently. And also, just to show you, this is one little quick thing that we pinched from North Devon. This is a little bag that we put all the discharge information in, and you can see our logo says, "We can do anything, Paediatric Diabetes Charitable Fund." We can do anything, isn't that great? So that was just
I prefer to call it group working.
Well, we didn't actually do that. We actually did a competition.
Yeah, that was a quick win one
competition for our
anyway.
patients.
Yeah, brilliant. So yeah, so we've achieved a lot.
So whilst our QI journey started in earnest following the post-diagnosis period, it became rapidly clear that the need to mend, honour, cherish, love, recognise our team was more paramount than any other single clinical parameter or action. The subsequent QI journey has seen us now singing often from the same hymn sheet. We get on with each other and communicate openly. We have come to accept that there are areas that we disagree on, but we know that to do so is for the best for our patients, and we have to deal with these issues. We've even been able to laugh about some of the disagreements. A clear strength of the team is the ability to move quickly, And leadership of the team has become more distributive, less clinician-led. We talk more, we laugh more, and we measure more. Time will tell if this is enough. It is clear that we have to do things appropriately for who we are and who our patient base is. Cycles of intensification may not be something that we can do, but sharing, enjoying, supporting our patients and each other to be the best they can be is who we are. Thank you for listening.